This podcast is specially produced by the Critical Care Education Foundation's Knowledge Hub project for you with the intention of providing a learning opportunity for doctors. It supplements the other material and self-assessments available on the CCEF Knowledge Hub project. Welcome, medical professionals. So imagine this scenario. You're on call, patient comes in, sudden, really dramatic neurological changes. Maybe they can't speak. One side of their body just isn't working right. That moment. That's when the clock starts ticking on a potential cerebrovascular accident or, what we commonly call a stroke. Today, we're doing a deep dive into strokes, and not just as a condition on a list, but as a real urgent emergency where every single minute counts, truly impacts patients' entire future. It's a huge cause of permanent disability worldwide, a major player in morbidity and mortality figures.
Absolutely. And that urgency, that race against the clock you mentioned, that's exactly why this is so vital for your practice. For doctors like you, right there on the front lines, swift, really aggressive therapy, ideally in a specialized stroke unit, that's the foundation. It's what improves outcomes. So what we've done is distill the most critical, the most actionable knowledge from the latest comprehensive sources. The aim is to arm you with what you need to know and know it fast so you can make those split-second decisions really count.
Right. Our goal today is to equip you with a sharper understanding of the different stroke types, the cutting-edge diagnostic tools that actually help differentiate conditions, and the very latest in both acute and preventive strategies. We want to highlight those key insights that can genuinely change how you approach these cases.
Yeah.
Okay, let's unpack this. Let's get straight into the details. So when we talk strokes, the first big split is ischemic versus hemorrhagic. They both affect the brain, obviously, but how they happen is totally different.
That's right. And because the how is different, the initial management is different too. Let's start with ischemic stroke, or ICVD, ischemic cerebrovascular disease. This is the big one. Accounts for something like 87% of all strokes. Basically, it boils down to not enough blood flow getting to a part of the brain because a blood vessel is blocked, occluded, and that leads to brain tissue dying off, infarction.
Okay, so a blockage. How does that happen?
Well, it can be a clot forming right there in a brain vessel. That's cerebral thrombosis. Think large artery atherosclerosis, like hardening of the arteries, or maybe a small vessel occlusion, or, and this is really common, it can be an embolism.
An embolism, meaning the clot travels from somewhere else.
Exactly. Like a clot travels from the heart, maybe an atrial fibrillation, that's cardioembolism, and lodges in a brain artery. And we absolutely have to include transient ischemic attack, TIA, here too. It's like a mini stroke, part of the same spectrum, a huge warning sign you cannot ignore.
Okay, so that's ischemic, the blockage type. What about the other category?
Right. The flip side is hemorrhagic stroke. This means bleeding, either bleeding into the brain tissue itself, which is intracerebral hemorrhage or ICH, or bleeding into the space around the brain, subarachnoid hemorrhage, SAH. They're less common than ischemic strokes, yeah, but they often pack a much bigger punch in terms of morbidity and mortality. They present a whole different set of challenges.
Got it. And going back to ischemic stroke for a second, you hear this term, ischemic penumbra. You mentioned it earlier, saying it's central to strategy. Why is that specific concept so critical?
The penumbra. Yes.
Okay.
Think of it like this. Imagine a part of the brain affected by the stroke. There's a central area, the core infarct, where the tissue is already, irreversibly damaged, gone.
Okay.
But surrounding that core is this region called the ischemic penumbra. Here, the blood flow is severely reduced, maybe down to 20–50% of normal. The brain cells aren't dead yet, but they're definitely not functioning properly. They're stunned, impaired, but salvageable.
Salvageable, that's the key word.
Exactly. That's the whole game. Our entire mission in acute ischemic stroke is to restore blood flow fast to save that penumbral tissue before it progresses to irreversible infarction. Identifying this penumbra, knowing it's there, knowing how much is there, that's what drives our treatment decisions, especially with newer therapies and extended time windows. It's where we can make the biggest difference.
That really paints a picture of the urgency. So if we're in this race to save the penumbra, how do we actually confirm a stroke is happening and, importantly, identify that salvageable tissue when a patient first presents? What's the diagnostic pathway look like?
Right. So the absolute first step, the initial imaging choice for any suspected stroke, is a non-contrast head CT scan.
Why CT first?
Two main reasons. It's widely available pretty much everywhere, and crucially, it's fast at ruling out intracranial hemorrhage. Bleeding. Because if there's bleeding, thrombolytics, the clot busters, are generally off the table, so you need to know that immediately.
Right.
And here's an important update for your practice. We used to think it took hours for signs of ischemia, the blockage, to show up on CT. But newer studies, better scanners, show subtle changes can sometimes be visible within hours, maybe even as early as 1 hour after symptoms start.
Wow. Okay, so even the initial CT might give us clues faster than we thought.
It can, yes. But then we often move to more advanced imaging to really map things out and guide treatment. CT angiography, CTA, or MR angiography, MRA, these look directly at the blood vessels, showing us which one is blocked, especially if it's a large vessel occlusion suitable for thrombectomy.
The thrombectomy being pulling the clot out.
Exactly. And then there's perfusion imaging, CT perfusion, CTP, or MR perfusion, MRP. These are the real game changers for identifying that ischemic penumbra we talked about. They show the mismatch between the area with severely reduced blood flow, the penumbra and core, and the area that's already infarcted, the core.
So that mismatch tells you how much brain is potentially salvageable.
Precisely. This is absolutely critical for deciding if someone's eligible for treatment, especially if they arrive late outside the standard window or if the clinical picture is a bit unclear.
And what about MRI itself? Any specific advantages there?
Yeah, MRI definitely has advantages. It's generally more sensitive than CT for detecting other things that might mimic a stroke, like a tumor. And it can detect the infarction itself earlier, sometimes within minutes of onset. Specifically, diffusion-weighted imaging, or DWI, is incredibly sensitive to early ischemic changes. It shows abnormalities way earlier than standard MRI sequences and helps differentiate true ischemia from mimics. And when you combine DWI with perfusion-weighted imaging, PWI, well, that gives you a really clear picture of the reversibly ischemic tissue. It's fantastic for guiding those advanced therapy decisions.
Okay, makes sense. What about lab tests? Anything crucial needed right away?
Yes, definitely. If you're even thinking about thrombolytic therapy, like RTPA, you need some basic lab stat. We're talking a complete blood count, CBC, coagulation studies like PTT and PTINR, and definitely blood glucose.
Why glucose specifically?
Because severe hypoglycemia or hyperglycemia can actually mimic stroke symptoms, and hyperglycemia can worsen outcomes. Plus, certain lab values are contraindications for thrombolysis, so you need those results fast. And ECG is also standard to look for atrial fibrillation or signs of cardiac ischemia, and often an echocardiogram later to look for potential heart sources of emboli.
Right, the diagnostic tools have really evolved. But once you have that diagnosis or a strong suspicion, it's all about that time is brain treatment phase. What are the mainstays of acute treatment for ischemic stroke?
Absolutely. Time is brain isn't just a catchphrase. The cornerstone, the only FDA-approved medication specifically for acute ischemic stroke, is intravenous recombinant tissue plasminogen activator 5-ERPA, or alteplase.
The clot buster.
The clot buster, exactly. It works by dissolving the clot and restoring blood flow. Traditionally, it could be given up to 4.5 hours after the symptom onset. But, and this is a major update for certain patients, carefully selected based on that perfusion imaging showing a salvageable penumbra, the window can be extended up to 9 hours.
9 hours, that's a big change.
It is. It opens up treatment possibilities for many more patients. The standard dose is 0.9 milligram per kilogram total, with 10% given as a quick bolus up front and the remaining 90% infused over 60 minutes.
Okay. And are there other thrombolytics used?
Yes. Tenecteplase, or TMK, is increasingly being used and recognized as another effective option. Some guidelines actually prefer it now, partly because it can be given as a single rapid IV bolus, which is, much simpler in an emergency situation compared to the hour-long infusion of alteplase.
Simpler and faster. Sounds good. What about actually removing the clot physically?
Right, that's endovascular therapy, specifically mechanical thrombectomy. This is incredibly valuable, especially for strokes caused by a blockage in a large brain artery, a large vessel occlusion, or LVO. Using catheter-based devices, often stent retrievers, we can go into the artery and physically pull the clot out. The standard window for thrombectomy is up to 6 hours from symptom onset.
But similar to RTPA.
Exactly. Similar to Part PA, for selected patients, again, based on advanced imaging showing that penumbra, that window can be extended much further, up to 24 hours in some cases, based on major clinical trials like DAWN and DEFUSE-3. Thrombectomy has shown really clear, often dramatic benefits for these LVO patients.
Makes sense. So reperfusion is key. What about other supportive care right after admission?
Oh, absolutely crucial. Supportive therapy starts immediately. Managing blood pressure is a big one, but it's nuanced. In the first 24 hours after an ischemic stroke, we generally permit higher blood pressures, often up to 118/30 and 110 milli-Hg if per PA was given, or even higher if not, unless there's a compelling reason to lower it, like malignant hypertension or other end organ damage. Lowering it too much could actually worsen perfusion to that struggling penumbra.
Okay, permissive hypertension to a point. What else?
Deep venous thrombosis, DVT prophylaxis, is vital, especially since stroke patients are often immobilized. That usually means subcutaneous heparin or low molecular weight heparin, meticulous temperature control, treating fever aggressively, assessing swallowing safety before allowing oral intake to prevent aspiration pneumonia, and encouraging early mobilization as soon as it's safe.
And after these initial reperfusion therapies, say after THRPA or thrombectomy?
Post-reperfusion care is critical. These patients need close monitoring, ideally in an ICU or a dedicated stroke unit. We're watching blood pressure very carefully, doing frequent neurological checks for any changes. And a key point, after giving RPA, we typically avoid anticoagulants and antiplatelet agents for the first 24 hours to minimize the risk of bleeding, particularly hemorrhagic transformation of the infarct.
That covers the acute phase really well. But the story doesn't end there. Once the immediate crisis is over, the focus has to shift to preventing another stroke, right? What are the key strategies for secondary prevention?
Absolutely. Preventing recurrence is paramount. It starts with aggressive optimization of the underlying risk factors. Number one is hypertension controlling blood pressure, ideally aiming for less than 30-80 millimeter Hg. ACE inhibitors or ARBs are often good choices here.
Okay, BP control. What else?
Hyperlipidemia. High cholesterol. Statins are key, with the goal of getting the LDL cholesterol down to 70 milligl or even lower in some high-risk patients. Then there's hyperglycemia managing diabetes, aiming for good euglycemic control. These lifestyle and medication factors are foundational.
Makes sense. What about medications specifically going to preventing clots?
Right. Antiplatelet therapy is a cornerstone for most patients who've had a non-surgical TIA or ischemic stroke. Standard options include aspirin, the combination of aspirin and extended-release dipyridamol, clopidogrel, or sometimes diclopidine, though that's used less often now.
Just one antiplatelet, or sometimes more.
Good question. For most patients long-term, single antiplatelet therapy is standard. However, there's a role for dual antiplatelet therapy, usually aspirin plus clopidogrel for a short period, typically about 3 weeks, after a high-risk TIA or a minor stroke. And also for patients with specific conditions like symptomatic intracranial atherosclerosis, maybe for 90 days or after carotid stenting. So knowing when to use dual versus single therapy is important.
Okay. What about stronger blood thinners, anticoagulants?
Anticoagulation comes into play mainly if the stroke was likely caused by cardioembolism, especially from atrial fibrillation AFib. In patients with AFib, anticoagulation significantly reduces the risk of another stroke compared to antiplatelets.
So warfarin, or
Yeah.
newer ones.
Historically, it was warfarin, aiming for that INR target between 2 and 3. But the newer direct oral anticoagulants, the DOHCs, drugs like dabigatran, rivaroxaban, apixaban, edoxaban, are now often preferred. They're at least as effective as warfarin, generally safer regarding intracranial bleeding risk, and crucially, they don't require routine blood monitoring or have the dietary restrictions warfarin does. That's a huge advantage for patients.
Definitely easier for patients. Are there any other, maybe more niche prevention strategies?
There are a few. For certain younger patients, say under 60, who have a stroke that looks embolic but have no other clear cause found after a thorough workup, and they have a patent foramen oval, or PFO, a small hole between the heart's upper chambers, percutaneous closure of that PFO might be considered. It's a very selected group, though.
Okay, PFO closure in specific cases. Any surgical options in prevention or management?
Yes, mainly in the context of severe stroke complications. For patients who develop malignant middle cerebral artery, or MCA, infarction syndrome, that's massive swelling from a large stroke, a surgery called decompressive hemicraniectomy can be life-saving. It involves removing a large piece of the skull to allow the swollen brain to expand. Studies show it's highly effective at reducing death and severe disability, especially if done within 48 hours of stroke onset. It's a major surgery, but critical in those severe cases.
Right, that's a really comprehensive look at ischemic stroke. Now, we need to pivot to that other category, the often more devastating one, hemorrhagic strokes. Let's start with intracerebral hemorrhage, ICH.
Okay, ICH. Bleeding within the brain parenchyma itself, it's the second most common stroke type overall, and as you said, often requires ICU-level care because it can be very severe.
What typically causes ICH?
About half the time, it's what we call primary ICH, usually linked directly to long-standing, poorly controlled hypertension causing damage to small, deep arteries. But there are other important causes. In older adults, especially with bleeds in the lobes of the brain rather than deep structures, cerebral amyloid angiopathy is common. That's protein deposition weakening vessel walls. Other causes include brain tumors, vasculitis, underlying bleeding disorders, sometimes bleeding into an area of prior ischemic stroke, or rupture of an aneurysm or an arteriovenous malformation, AVM.
Medications play a role.
A huge role. Antithrombotic therapies, anticoagulants like warfarin or the DOACs, and antiplatelet agents like aspirin or clopidogrel significantly increase the risk of spontaneous ICH. You always have to consider the patient's medication list.
How does ICH typically present? Is it different from ischemic stroke?
It's often more dramatic at onset. It's typically abrupt, with neurological deficits worsening over minutes to hours as the hematoma expands. Altered consciousness, severe headache, and vomiting are very common. And here's a key difference. Seizures are significantly more frequent right at the onset of ICH, maybe around 17% of cases, especially if the bleed involves the cerebral cortex. That's much higher than with ischemic stroke onset.
Okay, so potentially more dramatic, headache, vomiting, maybe seizures. How do we diagnose it definitively?
Again, the non-contrast head CT scan is the gold standard here. It immediately shows the blood, its size, location, whether it's causing midline shift or hydrocephalus, and the amount of surrounding edema. It's fast and definitive for ICH.
Can MRI be used?
MRI can identify acute ICH, but it's usually slower and less readily available in the emergency setting compared to CT. Where MRI or other vascular imaging like CTA, MRA, or even conventional angiography comes in is if you suspect an underlying cause for the bleed, like an aneurysm or AVM, especially in younger patients without hypertension, or if the bleed location is atypical.
And lumbar puncture, you mentioned it for suspected SAH if CT is negative.
Right, but for ICH, lumbar puncture is generally a contraindication. If you have a space-occupying hematoma inside the brain causing pressure, doing an LP could potentially lead to fatal brain herniation. So no LP if ICH is seen or highly suspected.
Got it. So treatment for ICH, what are the priorities?
The main goals are to stop any ongoing bleeding, prevent the hematoma from expanding, and manage the secondary brain injury caused by the blood and swelling. First step, rapidly reverse any coagulopathy. If the patient is on warfarin, you give IV vitamin K plus a prothrombin complex concentrate, like 4-factor PCC. If they're on a DOAC, we now have specific reversal agents for most of them, which is a huge advance.
Okay, stop the bleeding. What about blood pressure? Is it permissive hypertension, like in ischemic stroke?
No, generally not. For acute ICH, the goal is usually to lower the systolic blood pressure more definitively, typically aiming for a target between 140 and 160 millimeter Hg. There's debate about going lower, but aggressive lowering below 140 hasn't consistently shown benefit and might risk hypoperfusion. 5E agents like labetalol or nicardipine are commonly used.
And managing brain swelling, intracranial pressure.
Right. ICP management is key if there's significant mass effect or herniation risk. Hyperosmolar therapy using agents like mannitol or hypertonic saline can help temporarily reduce ICP. Importantly, corticosteroids, which are sometimes used for brain tumor edema, have been shown to be not effective and potentially harmful in ICH, so they are not routinely given. If the bleed causes obstructive hydrocephalus, placing an external ventricular drain, an EVD, to drain cerebrospinal fluid is necessary.
What about seizure prevention? You said seizures are more common at onset.
They are more common at onset, but routine prophylactic anticonvulsants for patients who haven't had a seizure are generally not recommended. The risk of developing later seizures isn't high enough in most ICH patients to justify the side effects of the medications. However, if a seizure does occur, clinically or on EEG, then it should absolutely be treated aggressively with anticonvulsants.
Okay. And
Yeah.
finally, surgery. Is there a role for surgically removing the clot?
This is a really complex and somewhat controversial area. For many ICH cases, especially those deep in the brain structures like the basal ganglia or thalamus, large randomized trials have generally failed to show a clear benefit for routine early surgical evacuation compared to medical management alone.
So mostly medical management for deep bleeds.
For many, yes. However, there are important exceptions. Cerebellar hematomas, bleeds in the cerebellum at the back of the brain, are different. If they're larger than about 3 centimeters or causing brainstem compression or hydrocephalus, early surgical removal significantly improves outcomes and survival. So that's a clear indication for surgery. Also, for lobar hematomas, those closer to the surface, surgery might be considered if the patient is deteriorating neurologically due to mass effect, although the evidence here is less definitive than for cerebellar bleeds. Minimally invasive techniques are also being explored.
That clarifies the nuances around ICH surgery. Okay, let's tackle the last major category. Subarachnoid hemorrhage, SAH. What defines this type?
SAH is bleeding primarily into the subarachnoid space. That's the space between the brain surface and the membranes covering it, where the cerebrospinal fluid circulates. It accounts for maybe 5–10% of all strokes.
And the cause. You mentioned aneurysms earlier.
Exactly. About 80% of non-traumatic SAH are caused by the rupture of an intracranial saccular aneurysm, often called a Berry aneurysm. These are weak spots or outpouchings on brain arteries. Other less common causes include rupture of an AVM, certain vasculitides, or sometimes stimulant abuse like cocaine.
How does SAH typically present? Is it that thunderclap headache?
That is the absolute classic presentation, a sudden onset, incredibly severe headache, often described by patients as the worst headache of my life. If you hear those words, SAH needs to be at the very top of your differential diagnosis.
So that headache is key. Anything else?
Yes, patients may also have a brief loss of consciousness at the onset, vomiting, and signs of meningeal irritation like neck stiffness or meningismus because the blood irritates the meninges. Interestingly, distinct focal neurological deficits like weakness on one side are actually less common right at the onset compared to ICH or ischemic stroke.
Diagnosis. Still CT first.
Yes, non-contrast head CT is the first-line investigation. It's very sensitive for detecting subarachnoid blood, especially within the first 6–12 hours of symptom onset.
What if the CT is negative, but you still strongly suspect SAH based on that classic headache?
That's a critical scenario. If the CT is negative but clinical suspicion remains high, a lumbar puncture is mandatory. We analyze the cerebrospinal fluid, specifically looking for blood or, more definitively after several hours, xanthochromia.
Xanthochromia.
It's the yellowish discoloration of the CSF caused by the breakdown products of red blood cells, mainly bilirubin. Its presence confirms that bleeding into the subarachnoid space occurred, even if the CT didn't pick it up. Once SAH is confirmed, you then need vascular imaging CTA, MRA, or conventional digital subtraction angiography, DSA, which is still often considered the gold standard to find the source, usually that ruptured aneurysm.
Okay, so you find the aneurysm. What's the immediate treatment?
Initial management is about stabilization, securing the airway if needed, managing hemodynamics, monitoring neurological function closely. Blood pressure control is vital, perhaps even more critical than in ICH initially, especially before the aneurysm is secured. We typically aim for a systolic BP below 140 or 160 millimeter Hg, or a MAP below 100 or 110 millimeter Hg to reduce the risk of the aneurysm rebleeding, which is often catastrophic. Then, the absolute priority is to secure the ruptured aneurysm to prevent rebleeding. This is done either through neurosurgical clipping, where a metal clip is placed across the neck of the aneurysm, or endovascular coiling, where tiny platinum coils are packed into the aneurysm sac via catheter to induce thrombosis.
Clipping versus coiling.
The decision depends on the aneurysm's size, location, shape, and the patient's overall condition. Coiling is less invasive and often preferred, especially for patients who are older or in poorer neurological condition if the aneurysm anatomy is suitable. The goal is to secure the aneurysm as early as possible, preferably within 24 hours of the hemorrhage.
And once the aneurysm is secured, what are the main concerns?
Preventing rebleeding remains key initially, by controlling BP, minimizing stress, preventing coughing or straining. Acute hydrocephalus is common due to blood clogging CSF pathways and often requires an EVD if consciousness deteriorates. But perhaps the most significant complication we battle after securing the aneurysm is delayed cerebral ischemia, or DCI.
DCI. What causes that?
It's often associated with cerebral vasospasm, which is a delayed narrowing of the large cerebral arteries, typically peaking about 7–10 days after the initial hemorrhage. This narrowing reduces blood flow and can cause ischemic strokes days later.
How do you prevent or treat DCI?
Prevention is key. The only medication proven to improve functional outcomes by reducing DCI is oral nimodipine, a calcium channel blocker. It's given routinely, 60 milligrams every 4 hours, for 21 days to all SAH patients. Maintaining adequate hydration or euvolemia and avoiding low blood pressure are also critical preventative measures. If DCI develops despite nimodipine, the first-line treatment is often hemodynamic augmentation inducing hypertension with vasopressor medications to force more blood through the narrowed vessels, assuming the patient is euvolemic. If that fails, endovascular treatments like balloon angioplasty to physically stretch the spasming vessel or intra-arterial infusion of vasodilators like nicardipine directly into the affected arteries can be used.
Okay, nimodipine, volume, BP management, and rescue therapies if needed. Any other important supportive care points for SAH?
Yes, similar themes to other stroke types: treating fever aggressively, DVT prophylaxis, usually starting with pneumatic compression boots until the aneurysm is secured, then adding subcutaneous heparin, and careful assessment of swallowing. One specific challenge in SAH is hyponatremia, low sodium levels. It's often due to a condition called cerebral salt wasting, which requires aggressive fluid resuscitation with isotonic or sometimes hypertonic saline, not fluid restriction like in SIADH. Managing fluids and electrolytes is really tricky but vital in SAH patients.
Wow, what an incredibly intense yet really eliminating deep dive into cerebrovascular accidents. It's just abundantly clear, isn't it? Whether it's ischemic, blockage, or hemorrhagic bleeding, the common thread is just profound urgency and the need for highly specialized care.
It really is. Both ischemic and hemorrhagic strokes are, without doubt, acute medical emergencies. They demand rapid diagnosis, specialized management strategies, all aimed at minimizing that irreversible brain damage and ultimately improving patient outcomes. And as we've discussed, the subtle but critical distinctions in pathophysiology, they dictate very different management pathways. That's the key.
Absolutely. And as medical professionals, you listening are right there on the front lines making these critical decisions, often under immense pressure. So, thinking about everything we've unpacked today, from the intricacies of penumbra imaging guiding ischemic treatment to the really distinct life-saving steps for ICH versus SAH, what aspect of stroke care do you personally find the most challenging? Or maybe, where do you see the most exciting potential for future innovation in your own clinical practice? It's a field that's constantly changing, and your perspective is invaluable. This podcast was specially produced by the Critical Care Education Foundation's Knowledge Hub project for you. We sincerely hope this deep dive has provided valuable learning, and we strongly encourage you to explore the other material and self-assessments available on the CCF Knowledge Hub project.